We've been dispatched to a 40-year-old male who has had a fall from a second-storey roof, approximately 6 metres, onto a concrete driveway, landing on his occupant. There is no family members present, so we're unable to gather a previous medical history, and he has no medic alert bracelet. The patient is lying supine. He's presenting restless and combative. His response to painful stimulus is rigid extension of limbs. He has got an injury to his occiput and an obvious boggy patch, which is approximately 6 centimetres in diameter. The patient is moaning, his breathing is irregular, and he's grunting respirations. On the vital signs, his heart rate is 50, blood pressure 160/110, resp is irregular at 12, his BGL is 7.6, temperature 37. He's got a GCS of 5, made up of E1, V2, M3, and SpO2 of 90. His indicator for RSI is his GCS is less than 10, and the ventilation is inadequate with the SpO2 at 90 and irregular rests. I've called for backup with RSI capability, which is approximately 10 minutes away. While waiting for the backup, we'll be treating the patient for severe TBI, looking at preventing this, preventing hypoxia, hypoventilation, and hypocardia. Blood pressure is above 120 systolic, so we do not need to give fluids at this stage. That will be getting IV access. We'll be treating the patient for hypoxia as his SpO2 is at 90, so we've got the oxygen mask here. While I'm waiting for the backup, I'll be going through the RSI checklist to prepare. So, attach nasal prongs with our oxygen. Pre-oxygenate the patient using a reservoir mask set at 10 litres per minute, or use a manual ventilation bag at 10 to 15 litres per minute with PEEP set at 5. So I've chose to use the mask here. Attach ECG, blood pressure and SpO2. So I've got the ECG attached, and blood pressure and SpO2. Prepare capnography if available. I've got my capnography here, attaching to my BVM. Position the monitor so it can be seen and leave space to the right side of the patient's head for the intubation equipment. So the monitor is able to be seen and there is space there for intubation equipment. Gain IV access in 2 sites, which I've already done, and prepare a line of sodium chloride, which is here. Position the patient for optimal airway control. I've done this by using the pillow. I've opted out of using a C-collar to get better positioning for the airway for RSI and to avoid secondary brain injuries to the patient. Place the ETT holder with the strap undone under the head. It's here. Ensure the suction is working. And place that under the patient's head. Prepare a manual ventilation bag with PEEP valve attached. For this OSCE I do not have PEEP, however I would attach it here. Obtain obtain a full set of vital signs. As read out before, I have the vital signs and I've written them down on this piece of paper, ready to hand over to the ICP on arrival. And finally, prepare the area, ensuring there is access to both sides of the patient. So I'm keeping all cords in one area so there is access to both sides of the patient. Once the ICP has arrived, I'll assist with the RSI. If they cannot visualise cords within 15 seconds or 30 seconds more than laryngoscopy, then we'll go into the failed intubation drill. So trying again with bougie, different blaze size, the bib, or changing the position of the patient. If that fails again, then we'll go back to basic ventilation with the LMA, and if that fails again, going into surgical airway, cricothotomy, which I have the kit here, which you just make an incision and place the ET tube in.